Insufflator is very important. One of the most important instrument in minimal access surgery is the CO2 insufflator, because most of the complication happens due to this machine. If your camera is not good, there is no much problem. You can find it out because it is visible. You can increase the shutter speed or decrease it. You can increase the light or contrast or brightness. If the light cable is not working, you can find it out. But the problem with the insufflator is only you will come to know once the complication happens. Because you cannot see the CO2 and you cannot measure your CO2 just by hand. Because it is something which is not easily can be measured. Pressure cannot be measured by us because we don't have any idea. Even in your car tire pressure, you need 1 meter to check it. Otherwise, we don't know it is high or it is low. And what are the complications which can happen due to the insufflator? Already we have discussed that if insufflator is not properly working, there may be decrease in the venous return, decrease in the minute volume, tidal volume. There may be decrease in the renal perfusion, decrease in the splanchnic blood supply, microatelectasis, cerebral edema, hypercarbia, and there may be sometime periorbitis, DVT, and sometime air embolism. So these all complications will be quadrupled if you will increase the pressure from 12 to 18. If you use the minimum pressure, these complications will be less. If your pressure is increasing, then it is in geometrical fashion, complication also increases. So our aim should be that we should try to learn the complete working of the insufflator, how it works. Insufflator, if you will see, it is of two types. One is analog insufflator, another is digital insufflator. Analog insufflator, they have a dial type of meter and it has a quadromanometric indicator. Quadro means 4 and manometric means pressure. This is called as preset pressure, this is actual pressure, this is flow rate, this is total amount of gas used, and then it will tell you the CO2, the cylinder also, how much pressure is there. Nowadays, analog insufflator, this is a Star's analog insufflator, which was very popular once upon a time. And actually it works, it also has a cutoff, it also has an automatic sensor, but those sensors are mechanical, they are not electronic. Just like you might have seen the ventilator of Siemens. The ventilator of the Siemens, it works completely on the oxygen pressure. It doesn't need any electrical supply. It is complete mechanical. Those are analog. But now all the new generation insufflators are, they are electronic, microprocessor controlled. They have a lot of electronic chips inside, which will let you know if something goes wrong. If there is a complication, you will immediately come to know. Now, when you are using insufflator, then first thing is the capacity of insufflator. When you go to buy the insufflator, the first thing they will ask you that how much liter insufflator you want. Like insufflator is available in market from 6 liter up to 45 liter. So the first question is which insufflator we should buy. What is the meaning of 6 liter? What is the meaning of 45 liter? 6 liter insufflator means the maximum flow rate is 6 liter per minute. And if 45 liter insufflator means maximum flow rate is 45 liter per minute. So which insufflator you should buy? Which one you will buy? Pardon?
The one who she says humidifier.
Okay, this is a good question, that what type of surgery I am doing, that is important. Now how you will decide? Suppose you are doing the cholecystectomy. How much capacity insufflator is sufficient?
20.
Yes, 15 to 20. That is 18 liter insufflators are available generally. That is okay. Why?
Because after I established motor running, the amount of gas escape rate might be maximum 60 to 80.
Yes. But if I want to do the splenectomy, then how much capacity insufflator I should buy? Pardon? No. If you want to do the advanced surgery, like splenectomy, nephrectomy, bariatric surgery, fundoplication, or colorectal, then you should have 45 liter insufflator. Why?
Time.
No, time
Can be
is not.
stopped.
Because there is leak.
No, there is no leak.
The flooring need to maintain the pressure.
No, the flow rate is not always necessary to maintain the pressure.
You have to maintain that.
Hmm?
Just do 18 is.
No, slanting circulation is also not.
Because
The reason is,
the time?
no. The reason is that emergency situation often arises. Like sometimes splenectomy, some of the short gastric or some of the renal or splenic vessel started bleeding. Now in that case, you have to put a 10 mm suction. You have to suck the blood. If your insufflator is only 18 liter capacity, then as soon as you will start suction, abdominal wall will collapse. And now you are in trouble. Because 5 mm suction sucks approximately 20 liter gas per minute. Because when you are sucking the blood, only blood doesn't come. Some gas also comes together. And 10 mm insufflator can suck up to 40 liter gas per minute. Suppose massive bleeding is there, and you are going with the suction to suck, abdominal wall collapse, tip of the telescope will touch the blood, and your vision is obscured. And now you are struggling, you are crying. And only option left to you is conversion. You have to open the abdomen and convert it. So, if you will take the high capacity insufflator, even if you are using suction, your abdominal cavity will be distended. But it is not like that. 45 liter insufflator always push 45. If there is no leak, it will not push the gas. If you have a high capacity insufflator, still you can do the diagnostic laparoscopy or cholecystectomy. But low capacity insufflator you cannot use, or it is very difficult to use for advanced procedures. Isn't it? Just like if you have a card, you can use for your office purposes. But if you have to go to fight someone, or if you want the same car to go to the border, to cross border country war, that car will not work. It is especially designed, high capacity vehicles should be there, which can go in the extreme condition. Isn't it? That is very high power and very especially designed wheels are there, which doesn't get stuck in the mud. It can go to the mountain, it can go to the deep shallow place, or even in the desert. But the same vehicle you can use for your purposes, even in your house also. You can go for buying vegetable by that also. But other way is not possible. So high capacity insufflator can be used for simple surgery, but simple capacity insufflator you cannot use for high capacity. Now, cost is very important. Cost of 6 liter insufflator is only 40 to 50,000 rupees. Cost of 18 liter insufflator will be approximately 1.5 lakh rupees. And if you buy a striker 45 liter insufflator, it is costing 6 lakh rupees. So suppose you are not, right now you are not ready to do the advanced surgery. You are starting your career and you are your initial stage of the learning curve, then it may not be necessary to spend that much money. You can go for a 18 liter insufflator average, that will cost you 1.5, and then up to 5 years you continue. Now once you have learning curve, you have reached to the stage then where you have to do the vascular minimal access surgery or the solid organ surgery, then you will change to a big high capacity insufflator, or sometime two insufflator can work together. Two 18 liter insufflator you can connect. One with one cannula, other with another cannula. So two 18 liter if you will connect, it will become 36 liter and then it will work. Insufflator should be microprocessor controlled, and that microprocessor gives you a lot of advantage and a lot of safety. Like suppose this is a varus needle and I have put the varus needle in, and after putting varus needle in, I am connecting the tubing of this varus needle here, and then I am switching on the insufflator. Now the insufflator is switched on, it is started, and it is giving you error message. This is error.
Why?
Now why this error is there? What I did wrong?
It's not closed enough.
Pardon?
Not in the abdominal cavity, not in the close.
No close space.
No, you
No.
close the.
It is locked.
Yeah.
Which one?
This one.
No, that also doesn't matter.
CO2 is not connected.
Pardon?
There is no
not connected.
CO2, but
No, CO2 there.
there is a gas.
No reset.
Can I just have a look?
Which one? Which one? I will switch it off.
Yeah.
It's an open system.
Stop.
Switch it on again.
First we have to
Pardon?
maybe not checking the virus needle or patency.
No.
Patency of the
error?
virus needle.
Error. See, it was open now. Then also error came.
Patency of the
Gas
virus
valve
needle
is
not
closed.
checked.
Pardon?
Cylinder valve is closed.
No.
No,
First you should set
No.
settings are not.
Settings first check and patency of the virus needle we didn't check.
No.
Not observed.
Tell me what is the wrong thing. Wrong thing is just like example I will give you. When your nurse is putting the IV cannula in the vein,
There is error.
yes, and if she will attach the IV cannula first, and then you attach the IV set, and then she will put in the bottle, will you keep that nurse? What she should do?
Clear the tube.
First she should put the, yes, turn it, and then
Remove some air.
remove some air, because right now, do you know what is there? Right now there is air in this tube. And if you will attach the insufflator first, and then you will attach the tubing, and then you will switch on the insufflator, at the time once this is coming, insufflator will immediately notice the varus needle and will give you the error. Do you know why? Because you could not wash out the air. So once you switch it on, first thing what is the, it is removing 800 ml of the air which was into the circuit. And then it will not give you error, it will come into the standby position. So never connect the tubing before switching on the insufflator.
Even if you force with your thumb, it will give error.
It will give error.
So it should be checked before entering the virus needle like this all.
It should be switched on before entering the varus needle.
Should
Right now up to the tip there is CO2. Because all the air which was in this circuit is flushed out. And then you put the varus needle and then connect. You know, after expelling 800 ml of the air, it is stopped now. Means it's not continuous because it is in a standby position now, automatically. And now to start the flow, you have to press this start and stop button. As soon as you switch on the power, it will clean the circuit. It will flush out all the air which is trapped into the circuit.
Okay, then it came out the flusher only. So
Yes.
it stopped here only.
Yes.
Okay.
And now there is CO2. Because if you will put the varus needle and accidentally tip of your varus needle is in any vein, and this, if 800 ml of the air will go, that 800 ml of the air will be sufficient to create air embolism to the patient. The patient may die. Just like the IV set, if the nurse will first attach to the cannula and then attach to the bottle, that complete air which is there in the tube can create air embolism to the patient. Isn't it? So this is one of the property of the microprocessor which is inside the insufflator. And if this air comes, immediately you should know that I have connected it. Again disconnect, switch it on, let the air go and then connect it. Sometimes people they confuse, they keep on switching, offing, on, and then error is coming and they are confused, what is the problem. And they ultimately they say that insufflator is spoiled. It is faulty, but it is not. Actually is our mistake. Other important thing, once it comes to the standby position, then you attach it. After attaching it, you have to switch on the insufflator to the varus needle mode. That is 1 liter per minute flow rate. Why we should switch on to the 1 liter per minute?
Because 2 liter per minute can cause air embolism.
Yes, because our body has a capacity to absorb the CO2 if it is directly going into the vein, even if the flow is up to 2 liter per minute. So safer is 1 liter. So keeping the varus needle flow rate 1 liter per minute has the advantage that accidentally if your varus needle is in any vein, then also patient will not die due to air embolism. And then you will start the flow. The flow is started. As soon as you will start the flow, insufflator will start giving you the pulsatile flow. This is pulsatile flow. Why this is pulsatile? Because of two reasons. One reason is that it wants to synchronize with the diaphragmatic movement, so that sudden increase in the flow will not create vasovagal shock. And another is that it is sensing the actual pressure inside the abdominal cavity when it is off. Because when it is flowing, at that time it is sensing the resistance through the flow of the eye of the varus needle. Because eye of the varus needle is very narrow. And once the gas goes from that small eye, there is always a resistance. So that's why this fluctuation is there. You can see sometime 18, sometime 12, sometime 3, sometime 12, sometime 0, sometime 18, sometime 16. Why this fluctuation is there? Because eye of the varus needle gives this resistance. So in pulsatile flow, real pressure is when the insufflator that is switching off, when it is not flow pushing the gas, and that is a minimum of the 5 reading. If you see sometimes 18, sometimes 0, sometimes 15, sometimes 5, sometimes 18, sometimes 12, sometimes 3, sometimes 12, sometimes 0. So what is the minimum of 5? 0.
0.
That means actual pressure is 0. If I will switch it off, it will become 0. Why actual pressure is 0? Because right now there is no pressure. We are in the atmospheric pressure. If the pressure is more, it will rise, like I am pushing it. And it is 20, 26. And if I will pull it, it will be negative, minus. This is preset pressure. Pull, I am sucking, then it is minus. If I will push, it is plus. If I will leave it, it is 0. Actual pressure is the pressure which is at the tip of the tubing. And preset pressure is the command given by the surgeon to the insufflator. When you perform diagnostic thoracoscopy, then you should not put any gas into the thorax. Just by double lumen endotracheal tube, diseased lung will be collapsed. Sometimes when you do the simple operative thoracoscopy, then some surgeons they will prefer to put some CO2 in the chest also, so that mediastinum will be little bit shifted and diaphragm also little bit pushed, so that their space is little more. Although more than 6 millimeter of mercury pressure, if you will use in the pneumothorax, then it will create the cerebral edema very fast. But CO2 if you are putting in the thoracic cavity for thoracoscopy, more than 6 millimeter pressure, then rapid cerebral edema develops, because chest cavity absorbs the CO2 much faster than the abdominal cavity. So ideally in the thoracoscopic procedure, simple thoracoscopic procedure, pneumothorax should not be created by CO2. Just you should use the double lumen endotracheal tube and diseased lung will be collapsed. As soon as you will collapse, automatically you will have the potential cavity, because rib will keep the thoracic cavity distended. Isn't it?
12 millimeter of mercury.
Yes. And maximum in thoracoscopy what you can use is 6. If you are using diagnostic laparoscopy under local anesthesia, you should keep it to the 8 millimeter of mercury. If you are using simple operative procedure, you should use it 12 millimeter of mercury. If you are using a standard operative procedure in general anesthesia, like cholecystectomy, appendectomy, hernia, hysterectomy, then you can use it to 15. If you are using, suppose, bariatric surgery or in obese patient or very distended abdominal cavity, or you are struggling with the vision, then you can go maximum to 18. Now after 18, you are not allowed to continue laparoscopy. If you will put more than 18, all the complication will be quadrupled. And you are waiting for accident to happen. Air embolism can happen, hypercarbia can happen, and all DVT, decrease in cardiac episode, acute respiratory distress syndrome, cerebral edema, bradycardia, all will happen. More than 18, not possible in laparoscopy. But suppose you want to do the TEP, totally extraperitoneal hernia surgery or retroperitoneoscopy, then you can go for the 22.
Extraperitoneal.
Yes. Why? Because it is not pressing the diaphragm, it is not pressing the vena cava, and peritoneal cavity absorbs the CO2 faster. Extraperitoneal cannot absorb that much faster. Only problem sometimes can be the air embolism. But if you are doing blunt dissection, that also is not a big issue. Sometimes when you do the axilloscopy, or then you can go up to 25.
This is the pressure inside the abdomen, yes?
Is the pressure inside the cavity?
And the upper one is
Preset.
Actually, no, preset pressure is the command which I am giving to insufflator to keep the pressure at that level. And insufflator will always try to keep the pressure at that level.
But not the actual level.
Yes, and what is the actual, that will told by the upper one. I am coming to that point.
So,
Suppose you want to come to the saphenous vein surgery in the septs and all, then you can go up to 30.
Great saphenous.
Yes. So this way, this is preset pressure. So I am coming again to 12. Why I am coming to 12? Because we are talking about laparoscopy. No, in this thigh, in the compartment, because at that very all the muscles are there, and you need to have very nice distance. It can happen. Yes. So you have to be careful. Now, above 1 is actual pressure. Now I start the flow. And actual pressure is slowly, it is rising. And if you see here, flow is starting.
This is no.
Okay. And it is starting the flow. And see, automatically the 12 came. If I will press it, it is how much now? 34, 35, 36 and gives alarm. And within 5 seconds, if you will not take the gas back, it will pull the gas in. Means it will withdraw the gas. I will show you. Here I am giving high pressure and it is giving the alarm. And it is taking the gas back.
Pulling.
Yes.
Taking.
So insufflator doesn't only push the gas, it takes the gas back also.
All insufflator?
All the insufflator. It has to be. Otherwise they will not get the FDA approval. Insufflator always try to keep the pressure at your preset pressure. It will try to obey your command. Whatever command you have given, it will try to keep the pressure at that level.
Even the analog ones.
Even the analog ones.
So this occurs for some patient. Do you want to sterilize the entire thing?
You do want?
To sterilize the entire stuff because patients have.
The gas.
No, it is not like that. It is going in the cylinder. There is one safety valve which opens and the CO2 is going in the environment.
It's because it is taken back.
Hmm.
So is it needed to sterilize the CO2?
Which CO2?
We're asking that.
No, because after taking, it is taking the CO2 only, and after taking back again, once the pressure comes again, the same CO2 comes inside.
Same cylinder can be used for
Yes, it can be used for others. And why it has not taken the CO2 immediately? Why it has waited for 5 minutes, 5 seconds, and then for 5 seconds no alarm, and then further 5 seconds there will be alarm, and then also if you will not withdraw, then it take the gas back. Do you know why? It is giving that much time. Why? Because it will give you the alarm that te means if someone is pressing the hand. Suppose nurse was pressing the abdominal wall. The alarm means remove the hand. Otherwise patient diaphragm is getting pressed. Isn't it? Whenever you see the alarm, that means there is someone pressing. And why it immediately doesn't take back? Because at the time of putting the trochar, always we give some pressure. So suppose you are putting the secondary trochar, then always you will hear this alarm. And if as soon as you started hearing the alarm, you should stop. So up to 5 seconds it will not give you alarm. Give the skin incision and go. But within 5 seconds, if you could not enter and you started hearing the alarm, then you should stop. In spite of hearing alarm, if you keep on continuing, it will withdraw the gas back and your trochar will hit the aorta or liver or the cecum. So withdraw the hand and again use next time, again you will get 5 second time. Is it clear? So suppose my trochar is there, I am pressing. Here I am pressing it. And this is 1, 2, 3, 4, 5. If I will hear the alarm, I will leave it. And again second attempt I will start. Again I will get the alarm. Again I will get 5 second time. I am buying again the time. Again I will leave. And again, most of the time within 5 seconds you are in. But if you could not enter, then remove the pressure, let it stop, and again borrow the 5 second time more, and again second attempt try it.
Remove totally.
No, just remove the pressure. Release the pressure.
Or increase this pressure.
Increasing will not do. Increasing is not good also, and it will not do. Why? It will increase, it will put more pressure. It will increase the intra-abdominal pressure.
Then it's safer when you are increasing the distance.
If you are increasing the distance, although according to the SAGE's guideline, before putting the first trochar, you can increase to 20, 25 also. But we are not talking about the first trochar. First trochar will never give you alarm. Because first trochar, at the time of introduction of the first trochar, there is no insufflator attached. It is attached with a varus needle. Isn't it? We are talking about the secondary trochars. And during secondary trochar, pressure should not be that much high. And you don't need it also, because secondary trochar is under vision. Isn't it? So just release the pressure and attempt second time.
Just release from peritoneum like this. Or
No. Suppose I was pushing and I have the alarm.
Skin
Then,
on the
yes,
skin.
yes.
Skin on the skin.
And then I will release and again attempt.
I understand.
Just release little bit, pressing effect. And automatically alarm will stop. Am I clear? So this is also the microprocessor inside the insufflator, which is giving you this idea to do. And you should not ignore these alarms. Alarms has a lot of meaning. And what alarm, which type of meaning is there, that we should understand. Now, once you have started cannula, all cannula is in, then you will change it to the 0 to max. That is high flow. Even if you will push your insufflator to the high flow, flow will be 0. It will not form. High flow means it is ready for high flow now. If you are setting the insufflator to the 10 liter per minute, 20 liter per minute, 30 liter per minute, that doesn't mean that insufflator gas will flow at 30 liter per minute. That means it is ready for 30 liter per minute. And flow rate will be automatically adjusted according to pressure. So if there is no leak, it is 0, and now I am leaking. And when I will leak, see, what is the flow rate?
3.
Now I am leaking 6. And still the actual pressure is 12. Still the actual pressure is 12. And still the preset pressure is 12. And actual is also 26. 6 is flow rate. Actual pressure is above the preset pressure.
Actual pressure 12.
And preset pressure 12. And flow rate is 6. And still this gloves is erect. Isn't it? Now I am closing. When I will close it, then also actual pressure is 12. And flow is stopped. Isn't it?
Yes.
So insufflator always try to keep the pressure at preset pressure. And if the gas flow is not there, it will not push the gas. If gas flow is 1 liter per minute, it will push 1 liter per minute. If gas flow is 40 liter per minute, it will push 40 liter per minute. In this insufflator, there are only 2 settings. One is varus needle mode and other is cannula mode. Varus needle mode you will keep 1 liter per minute. And in the cannular mode you will keep high flow rate. But in the starch insufflator, there is one bar. There is one like a mercury column. And when you will press plus 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 plus, this is lighting up. Have you seen that? And when you do the minus minus minus, it is lighting down. And it is not here, this is 2 mode only, varus needle mode and cannula mode.
This is analog.
This is digital. And in the starch also the digital one, manually you have to adjust the flow rate. Then which one is good? This is good or that one is good? Pardon? That one is good. Why?
I can maintain.
What is the need? Why I will adjust?
According to operation procedure, diagnostical.
Now, once you, after putting varus needle, once you confirm that varus needle is inside, you can increase.
Here also you have the varus needle mode. Here also you have 0 to 1 varus needle mode.
No, once they show that it's
This
inside
one is-
abdomen, we can increase the flow rate.
Here also you can increase. Anyway, varus needle I cannot allow more than 2.5 liter per minute gas to go.
Automatic flow.
Which one? Manual one? No, it doesn't flow. If manual one, if you are adjusting to 6 liter per minute, that what does it mean?
It should not go beyond that.
It should not go beyond that. But it will not go at that. Putting 6 liter per minute doesn't mean that insufflator is flowing 6 liter per minute. Don't keep this confusion in the mind. The advantage is it is safe to prevent the hypothermia and to prevent the dryness of intestine. Suppose this insufflator has only two modes. One is 0 to 1. It is written. 0 to 1 means when the pressure comes to the preset pressure, it will become 0. And when the pressure is less, maximum flow rate is 1 liter per minute. And another is 0 to max. When the pressure reaches to the preset pressure, it is 0. And when pressure is below the, it will flow maximum flow rate. So suppose some of the cannula valves are open, or at anywhere suppose some gas was leaking. Then in those situations, this insufflator will not give you any alarm. You will keep on performing surgery, and suppose 8 liter gas was leaking, then it is compensating 8 liter gas.
Even outside leaking.
Yes, leaking, that's why it is compensating it. And now at the end of the surgery, after 1 hour, patient will start shivering if it is in light. If it is deep anesthesia, he doesn't shiver also. And the temperature we will see in the sensor, in the multipara monitor comes down, and patient in the extreme cold weather can create the ventricular arrhythmia and death. Because rapid evaporation of the fluid through the splanchnic bed will create the blood coming to the portal vein completely cold. And that cold blood goes to the vena cava, and that leads to the heart, and once it will create ventricular arrhythmia, there may be death. If you have the manual insufflator, and if you have set to the 5 or 6 liter per minute, then as soon as the leak is more than 6 liter per minute, your abdominal wall will collapse and it gives you alarm. That will draw your attention and you will stop the leak. Just like cruise control of your car. In the car there is cruise control now. If you set to the 60, even if your driver press more, car will not go more than 60 km per hour speed. That is in the hand of the owner. You can set the cruise control and you can lock it. Now car is fixed to the 60. But suppose bleeding has started, then again you have to tell your nurse to put to the maximum flow. Here it is not there because there is no cruise control. Just like cruise control is 60 or 100 you have fixed, but some terrorist or some kidnapper is coming, then this cruise control may be dangerous. Yes.
Is there a mechanism in which alarm can be set about 6 liter or 8 liter in this one?
No. It is not in this one.
Not even alarm.
Not even alarm. If it is leaking, it will compensate.
So if alarm was there, that was enough.
Yes. But here it is not, because it is thinking that you are sucking or it is a need. So actually the manual one is good. But manual word, don't confuse that manual is also more automatic actually. Word manual is that flow rate you have to adjust. But when you are flowing adjust, what you are actually adjusting? Maximum flow rate. You are not adjusting flow rate. You are adjusting the maximum flow rate. If the leak is not there, even if you will adjust to 6 or 8, flow will not be there. Isn't it? But if the leak is more than 8, then also it will be 8 only. And then it gives you alarm. So that it draws your attention that now my limit has been crossed. You are doing something wrong. And if you know that purposefully I am doing wrong, like I am sucking or irrigating, then it is okay. Or if it is emergency, then you will tell to increase to the high flow. In some insufflator there are 3 settings: low flow, medium flow, high flow. They don't have manual also, they have given 3 settings. Low flow is for medicinal, medium flow is for surgery, and high flow is for emergency. But high flow doesn't mean that it will flow high if it is not required. High flow means it is ready for charge for high flow. Is it clear? So all the insufflators are basically automatic. Manual, it may be dangerous. Suppose it is 3 liters per minute, if you are forcing, abdomen will burst. Insufflators are never sensitive for the flow rate, they are sensitive for the pressure. If the pressure is less, it will flow. And if pressure reaches to the optimum preset pressure, it stops. All the insufflators. And flow rate is decided by the amount of decrease in the pressure. If pressure suddenly decreases a lot, it may go to the 45 liters per minute. But if the leak is only 1 liter per minute, flow rate will become 1 liter per minute. Automatically it is adjusted. So more than 6 liters per minute flow for more than 5 minutes can lead to 2 complications. One complication is hypothermia, other complication is dryness of the peritoneal fluid, intestine. Now to compensate it, you can use CO2 warmer. But if you will use CO2 warmer, dryness of intestine will be more. If you are putting CO2 warmer and then also you are leaking, that means you are drying the intestine with hair dryer. Isn't it? To compensate that, you can buy the CO2 warmer with the humidifier. But that will cost you a lot. So generally better not to leak. Now,
CO2 warmer, the one which make the patient wear it, it is all body and...
No, it is inside the insufflator itself.
Yeah.
There is one coil, electrical coil, that is for body warmer.
They make them all laparoscopic body warmer.
No, see it is, only CO2 is warm, then it is warm.
Alright.
Body warmer may be necessary in the extreme cold weather to keep the patient body warm. But inside the abdominal cavity, you cannot make it warm by body warmer. Inside abdominal cavity, you can make warm only by the CO2 warmer. Normally CO2 is always cold. Why? Because it has converted from liquid to gas. So liquid CO2 once converted to the gas, it is extremely cold CO2. And that's why if you will not keep it warm and if you are leaking, that means just by after having a shower you are standing below a fan. And then you are shivering. And problem is not body temperature is one of the important factor, but even if the body is warm, but that cold CO2 is touching the splanchnic, the intestinal splanchnic bed, that is the major reservoir of the blood, and then cold blood, portal vein, and then to the vena cava, the cold blood it enters into the heart, even outside is warm, but inside the heart is a cold blood, so arrhythmia happens. And that is one of the cause of the death in the extreme winter season if you are using the cold CO2. Even if you are using the warm CO2, you don't have humidifier, but if you are not leaking, then the humidity will be maintained. So leaking is not good. Why leaking is not good? Because it is not good for you also. Now tell me, if you are leaking, patient will get hypothermia and the dryness of intestine. But it is have any bad effect on you?
Yes.
What?
Because, when you start leaking the abdomen as well, the gas will not leak in there. Pressure it will drop.
No, that is true. Pressure will drop, but if you have a high capacity insufflator, pressure will not drop. It will compensate.
Carbon dioxide concentration atmosphere increases.
Okay, if the carbon dioxide in atmosphere increases, it have any bad effect on us? What?
Ventilation modes.
Pardon?
rate of the respiration will be more.
If it is more carbon dioxide in the air, then
Yeah.
Acidosis make acidosis.
Acidosis. You know, CO2 is not a poisonous gas. CO2 is not supporting the life, but it doesn't kill the life. During the vigorous sexual exercises and marathon, every human body is expelling 200 ml CO2 per minute its own. It comes in our breath also. 200 ml CO2 per breathing you are expelling out.
lead to dryness,
Pardon?
skin dryness.
No, it is very good gas. CO2 increases the hemoglobin. CO2 is not pollution. Even the CO2, whatever it is right now in the environment, if 1000 times concentration of CO2 increases, it will not kill you. Carbon monoxide, sulfur dioxide is the dangerous. So if 2-3 liters CO2 comes in the OT room, no problem. You will not never be affected. But anesthetic also doesn't have any problem.
Cost is increasing.
Pardon?
Acetic gas they give to the trauma cavity and it escapes when leaking.
No, anesthetic gas, nitrous sometimes diffuses, but that is also not an issue. If the CO2 pressure is there, it doesn't allow that escaping into the cavity because it will compensate it. Problem is, if it is medical grade CO2, it is not harmful if 2, 3, 4 liter gas is leaked. If it is suppose 2000 liter gas will be leaked in this room, then it may be that we have get little bit drowsiness or headache. But don't think that if you are inhaling CO2 it will kill you. We produce our own CO2. This is not carbon monoxide or sulfur dioxide. CO2 is useful for some bacteria. They need CO2. CO2 is used by plant for photosynthesis. CO2 is not a poisonous gas. Although it is not supporting the life, it is anti-combustion, but it is not poisonous. But problem is that many of the operation theatre, they have supply of industrial CO2. And industrial CO2 is bad. Tell me, where is the maximum use of the CO2 in the industry?
Soft drinks.
Soft drinks. Soft drinks, one bottle of the soft drink has a 500 ml, half liter of the CO2. That's why it is called as carbonated drink. So when you drink the Pepsi or Coca-Cola, this CO2 is coming through your mouth. Because once you have regurgitation, it is coming. CO2, you are expelling out the CO2. But those CO2 is also medical grade. Another use of the CO2 is by the fabricator. Fabricated, when they do the different construction of a building or making a grill, they use CO2. Another use of the CO2 is in bakery industry. You know how they make the bread? How they make?
Fermentation.
Yes, they put the wheat flour in the ground, on the room, and they put the water there and they walk over those wheat. With the leg, with the foot, they will mix all the wheat. Although nowadays, to prevent the problem, they wear a rubber boot. But in some places they don't wear that also. And they mix it with the water with the wheat. After that they put the yeast. Yeast is fungus. And they put some CO2 gas there. It is anaerobic. And once the yeast get the CO2, it started fertilizing, reproduce, and eating those wheats. And they make the hole in the wheats in the process, and then defecate and vomit. So each one hole of the bread is one toilet of the yeast. The bread which you are eating, all the holes are one toilets. Where the yeast goes and it vomits and defecates, and due to that fermentation happens. And due to that fermentation, the bread gets so much soft. And the same yeast also you are eating, although it is a high source of vitamin B12, isn't it? Yeast is, and the bread it has. It is helpful, but the CO2 is not good because they are making by crude technique. because it should be very cheaper. So that industrial CO2 if you will use, then it is harmful.
So bread is harmful in this way.
Yes, and the problem is that sometimes due to the compressed pneumoperitoneum, you have used harmonic or monoproranol, it has viral DNA, bacteria and carcinogenic material also. So leaking the CO2 is harmful for surgeon also, because it is not only a pure CO2 which is by our respiration we are expelling out pure CO2. We don't exhaust the carbon monoxide and carcinogenic material or sulfur dioxide or dust or smoke. That CO2 doesn't harm. But other CO2 which is used, it should not be. Another problem is if you have a bad industrial CO2, patient will complain more shoulder tip pain because there will be more irritation of the diaphragm. So it is better that when you buy the CO2, you should get a certificate that it is a medical grade.
Medical grade means of percentage grade.
Yes, percentage is different and it is completely filtered. It is from the biomedical gas industry. Industrial CO2 is, it is written that industrial CO2, medical CO2 is certificate vendor they carry. Because medical grade CO2 is more costly than oxygen and nitrous. That's why they do to make the money. So this is the total amount of gas used and the flow rate that is important, we have to monitor. Now the last is total amount of gas used. Right now what it is showing 12.4 means till this insufflator was switched on, I have wasted 12.4 liter of the gas in this room. Isn't it? Now minimum amount of the gas required to distend the abdominal cavity to reach the pressure to 12 before putting the first trochar is 1.5 liter and maximum is 6 liter. Means minimum 1.5 liter gas should go in to reach the pressure at 12 and maximum it should go 6. Now what are the variables? First variable is size of the patient. If the patient is very tall, of course you will take more gas in the abdomen. If the patient is very small, you will take less gas in the abdomen. Another variable is pardon? Parity means relaxation of the abdominal cavity. Suppose very old patient, 70-year-old grand multipara female, and one is young 18-year-old nulliparous woman. Young nulliparous within 1.5 liter it will reach to 12, and in the grand multipara old lady up to 6 liter is required to reach the same pressure. Another is muscle relaxant. If anesthetist has given a nice muscle relaxant, you will be able to put more gas inside the abdominal cavity and that will be safer. More gas means there is a more distance of the abdominal wall from the bowel and the great vessels, isn't it? And if the anesthetist is keeping the patient light, or some people they do in that spinal or epidural anesthesia, in that you cannot give muscle relaxant, otherwise the respiratory muscle will get paralyzed. So in those situations, within less gas only abdominal distension will be complete. Because actual pressure once reached to the preset pressure, further gas flow stops. Another is bowel preparation. In bowel preparation you have done very nicely. In some time in the colorectal surgery or the radical hysterectomy, bowel preparation starts maybe 1 to 2 hours, 1 week before the procedure. You have to give the fiber-free diet, and then 2 days before Preglet powder, and then prior to the night you will give some tranquilizer, and then in the morning you do, and then you will get a very thin collapsed intestine, and it will be easy to perform surgery. So bowel preparation makes a difference. Another variable is the anesthetic agent which you are using. Nitrous creates distension of the intestine, and it decreases the cavity pressure. Means you will have less volume of the abdominal cavity, and with less CO2 it will be filled up. If you are using isoflurane or sevoflurane, then you have more space. Another variable is any space occupying region, like big fibroid, big ovarian cyst. All the entire abdominal cavity is filled by that region itself. So for our CO2, there is minimum space now. Another is some fluid, like hemoperitoneum. There is a rupture ectopic. Already 2 liters blood is inside the abdomen. Or patient has ascites. Then you will not be able to put any gas. Because the cavity which has a 1.5 liter capacity, all the capacity is filled up with the blood or with the ascitic fluid. Then in those situations, first you have to drain all the fluid out, and then only you will be able to put something inside. So our intention should be that as soon as patient comes and it lie on the table, and during anesthesia itself, just see, palpate, lift it, see the laxity, see the size, and fix the idea in mind that how much gas he will take or he will take. And that is very useful. You know, this is the actual pressure. Just seeing the actual pressure and total amount of gas used will let you know where your gas is going. And how to do that, I will tell you. Now, suppose this preset pressure is 12. Then the minimum 1.5 and maximum 6 liter gas will accommodate. But if I will increase this preset pressure to 18, then it will be doubled. If at 12 millimeter preset pressure, minimum 1.5 liter gas is required to put in the abdominal cavity. But if I will put this pressure to 18, then it will take more gas. Why? That means you are compressing it. Am I clear? Just like here, I will just demonstrate you. Here it is, I am putting to 12 and I am starting the flow. I am resetting it. It is reset. It is reset and I start the flow. I am putting 0 to max. And how much gas it has taken? Only 300 ml. And 12 is reached it. But I am increasing it now. I am increasing to 18 or 25. See now? It will take a lot of gas now. Can you see that? It has taken already 1.2. See how it is happening. If you are putting that way the gas, the same situation happens to the abdomen. And it will take more gas. And it can burst.
Even the abdomen?
Abdomen will not burst, but diaphragm. Abdomen will burst if you go to the 100 millimeter of mercury. But abdomen will not burst, but the organs will, yes, vessels are. So, at 12 millimeter of mercury pressure, even if I will keep it for 1 hour, it will not be disfigured. This gloves is not disfiguring, it is only distended. So abdominal cavity should only be distended, it should not be disfigured. Isn't it? So this minimum 1.5 and maximum 6 liter of the gas I am talking about is 12 millimeter of mercury. In some of the book you may see that this is going a little high, but that is because they keep it to 15. So don't get confused with that. If I will increase the preset pressure, of course it will, if I will increase the preset pressure, to 100, it can take 50 liter gas. Same cavity. Do you know why? In this cylinder, that much a small cylinder, there sometimes you can put 200 liter gas. Because once you keep on compressing, gas turns into the liquid CO2. I will also tell you how to know that how much CO2 is there in cylinder and which cylinder take how much gas, that also I will discuss later. So this is total amount of gas used is 4.4 liter. Now, minimum 1.5 and maximum 6 liter is required to reach the preset pressure at 12. Now question is, how much is required for surgery? This is the amount of gas which you need to put into the abdominal cavity before putting your first trochar. Isn't it? Now the question is, how much you need to continue your surgery. Generally, for 1 hour of the surgery, 18 liter of the gas is used. In that 18 liter, approximately 20%, that is 3.6 liter, is getting absorbed in our circulatory system to the peritoneum. Generally, for 1 hour of the surgery, 18 liter of the gas is used. And in that 18 liter, 20% is absorbed. Like in 1 hour, 3.6 liter of the gas is going into our blood circulation. But through our respiration, we can easily wash it out, unless the patient has some cardiac or pulmonary disease. If the patient has some COPD, like tuberculosis, bronchial asthma, bronchiectasis, or some cardiac disease through which the cardiac output is less, bradycardia is there or some other problem is there, then patient will not be able to wash out that CO2, and that's why the cardiac and respiratory patient, they develop hypercarbia. Isn't it? And hypercarbia lead to the cerebral edema lead to the bradycardia, and bradycardia increases further hypercarbia. But normal patient, for 1 hour, 3.6 liter is nothing. They can easily wash out. But at the end of the surgery, suppose you have seen that I have used 80 liter of the gas in 1 hour.
80?
Yes.
80.
80. Then what does it mean?
That means pressure is high.
No, pressure is not high. That means pressure leak. That means we are foolish. And this is my fault. I should penalize it for me for this. I should give penalty to myself. Why? First, I have lost the money unnecessarily. Second, I have put my patient in the danger of hypothermia and dryness of intestine. If due to any reason it happens and you recognize during surgery, immediately take the normal saline and sprinkle the normal saline all over the small intestine.
Warm saline.
Normal saline.
Warm.
If it is cold weather, then it is warm. If it is summer season, maybe normal. Isn't it? And you should sprinkle the warm saline all over so that humidity will be maintained.
If I discover there is a lot of
Gas leak and my surgery is prolonging, which is not necessary for diagnostic laparoscopy and ovarian drilling. But suppose you are doing radical hysterectomy or any solid organ surgery, and surgery has continued 3-4 hours, then time to time you should keep on irrigating the intestine here and there so that humidity will be maintained.
What's the risk of dry intestine?
Risk of dryness?
Adhesions?
Yes. When you do laparotomy also, when you are putting the intestine outside, will you let it dry?
no.
What up to that?
Yes, wet. Why? Because dryness means serosa is damaged. Continuous fluid is needed by the serosa of intestine to keep alive. If it is dry means complete serosa is dead now. And immediately you need to, and there will be complete bowel aperistalsis, paralytic ileus and interbowel loop adhesion. Isn't it? So that's why it needs moisture, fluid. Intestine is very sensitive to dryness. And that's why you should not leak. So total amount of gas used is very important indicator, which is for safety you have to keep in mind that I should not let it go high.
Sir, what is the maximum flow rate that we will set in Stoll's manual insufflator?
For suppose you are doing college hysterectomy, then put it to 6.
6.
If you are doing suppose splenectomy, then you put it to 45, because if the artery started bleeding, then you don't have even time for nurse to tell and tell to go and increase it, because she will do something wrong and then your attention will be withdrawn. Just like if you are going for just have a fun, then you can put cruise control of the car on. But if you are going to kidnap someone, you will not keep the cruise control on, because after picking it you have to run away, isn't it? And at that time there is a life and death situation. You will keep cruise control 40 km per hour. One motorcycle will chase you and catch you there. Exactly the same way, manual means it is a cruise control.
For appendix cholecystectomy and all 6 liters.
6 liter is always better, but even in those surgery, if emergency starts, like suppose cystic artery is cut, bleeding is started, and you are using suction and abdomen wall is collapsing, you have to increase it to the high flow.
So hysterectomy, 6.
6, 8. Even if you will put 45, there is no problem. But if you are putting 45, time to time you should see the flow rate. Isn't it? Like if you are not doing cruise control in the car, no problem. Time to time see that your driver is driving at which speed. In the car where the cruise control is not there and your son is driving, you are telling her not what you are doing, slow down. Because you see that it is going 100 more than 100. You will say, no. The drive slowly. We say that. We don't need cruise control. You don't need to keep it at 6. You keep it to 45, but be attentive. But generally in laparoscopy nobody is seeing insufflator.
Yeah.
Because you are busy and you are so much anxious in your surgical task that who will see insufflator? Isn't it? Nobody sees insufflator. So putting it at that, nobody sees.
We see it at the beginning.
No, we see only when the problem happens. If the gas is not coming or abdominal cavity is collapsed, then we see what is the problem. So let it do it and set it to 6. So that automatically it will adjust it. And insufflator has a lot of safety. So this is the total amount of gas used.
Total amount of gas used. Suppose there is leak. Why it will become down?
If it is, suppose if you will put the maximum flow rate to 6 and the leak is at 6.5 liter per minute, then it will go down.
Use this gas.
Because it is coming maximum at 6 and leaking at 7.
No gas.
Yes.
Because in private hospital they calculate the amount about this figure. How it is used to gas.
Yes, that they do. Yes, it is important. It is important that they calculate that how much CO2 you have used.
So if leak it is good.
No, then according to that they charge the patient.
Yes.
Doctors never pay.
No, I don't think that anybody charges for the amount of CO2 used. I
Gas
don't.
can be leaked.
In Egypt, everybody is paid for everything.
No, if it is charged that way, at the end of surgery you can inhale some CO2. So that the charge will increase. But generally in our hospital, we don't charge for this amount of CO2 which is used. Pardon?
They do charge.
And
For
gas.
CO2.
Yes, in Egypt you charge it by the liter. By liter, how many liters did he use? Same like nitrous. Same way.
Okay, if they charge, then I will not tell, but you have to take care of safety of the patient also.
Is there an upper limit? Can you set the upper limit for that?
Upper limit for?
For this gas leaking or...
No, total amount used.
No. Only you can reset it.
Yeah.
Only you can reset it. Suppose second patient comes, and again just like petrol, once they put one car and another car they reset it.
So, today also it's 12.4. Yesterday there also it was 12.4.
No, actually, sometime what happens, in some insufflator, at that pressure it stops. This is one problem with this insufflator. You might have seen, more than 2500 it gets stopped, it gets locked there.
Okay. So usually it shouldn't happen.
No, it should not. It can go 100 also. So this was regarding the quadromanometric indicator. Quadromanometric means 4. All the insufflator of the world has these 4 indicators there. Preset pressure, actual pressure, flow rate and total amount of gas used.
The flow rate
Now-
will be 6.
Flow rate will be, it doesn't matter, as you want, as much as you keep the flow rate, insufflator will automatically decide what should be the flow rate. But if maximum flow rate you can control. So maximum flow rate should be 6 or 8 when you are performing the surgery. That is called as medium flow. And in emergency, you should increase it to high flow.
There should be any safety alarm for these things. That after 50 liters, they should give us some.
In some of the insufflation, you can set it like that, but it doesn't matter. Why? Because it depends upon the duration of the surgery. Sometime like esophageal pull-through surgery or gastrectomy or hemicolectomy surgery continue up to 6 hours. So that's why they don't give alarm.
What's the upper safe limit of the flow rate? For example, in laparoscopic listing, upper safe limit of flow rate.
6 to 8.
The highest level.
Highest level. Because if you are leaking more than 6 liters per minute for more than 5 to 10 minutes, there will be hypothermia.
What should be the temperature?
If you have already CO2 warmer and humidifier, then you are allowed to leak as much as you can. Then you can charge the patient.
What should be
But only problem will be for you. Isn't it? If the humidity is maintained and the temperature is maintained, then there is no harm of leaking like a CO2. It is just like a laminar flow, it keep on leaking. Although then also little bit dryness will be there. Even if it is humidified, little dryness, because it is Bernoulli theorem. Whenever rapid flow is there, evaporation is there. On the same principle, all the cooling system of the cooler or AC works. Because of the flow, it becomes cold. Wherever there is a flow, it becomes cold. Isn't it?
what is the temperature of the CO2 when we are using only warmer?
If you are using, that is approximately little high than the body temperature. It is approximately 35 to 36 degrees centigrade. Little more than the body temperature, so that it will keep it warm.
So this warmer and humidifier unit is a separate one or is it is inbuilt?
Pardon? No, inbuilt. CO2 warmer with the humidifier, it is there already. If you will tell, I will. So बोलो एक वार्मर वाला इंसफलेटर लाके दिखा देने के लिए. हो सकता है सुमित के पास होगा.
So this is the digital analog, nowhere.
Humidifier connection is very expensive because there is a separate circuit, because sterilization is one of the issues. Whenever you are attaching the normal saline, that circuit should be disposable. Isn't it? Because if it is the same fluid is kept for second patient, that fluid can get the bacteria and the other infection inside.
You know, what about sometimes you see in our hospitals all the tubes are connected to filter.
The purpose of this filter is, if this is industrial grade CO2, then also the smoke and the particles and the dust of the CO2 will be filtered. Another advantage is, any time any fluid, any time any fluid should not enter, any time any fluid should not enter from this tubing. Sometimes you are doing TLH or LAVH. And in LAVH, half of the procedure is done laparoscopically, half is done vaginally. At that time, suppose accidentally this was attached, all those insufflator is switched off. And instruments are removed, but the cannula is still there. Abdominal collapse, and that cannula is touching the fluid. And if that fluid enters into this, it will get spoiled.
So
The
that's
purpose of the filter is, don't allow the fluid to enter through this and don't allow the dust to come out of that. And filter time to time can be changed. Here, if this insufflator, if you see, it has the temperature here. Can you see? And this is the 1, 2, 3, 4, and here this is the volume and this is temperature. And this you can give you a 35 degrees centigrade, you can adjust it. So this has a CO2 warmer. And here. And see this is 21, 23, right now it is the room temperature of the environment, but you can set it. and you can increase it. So this is set. This is the actual rate flow, and this is set to. This is the flow rate you can set.
This is the preset.
Yes. So this is heater is on, and now if you see it is heating, and if the air comes here, it will be hot CO2, isn't it? Although it is not connected to the tubing right now.
That temperature I can maintain.
You can increase or decrease the temperature also. Right now it is giving the temperature of the environment because the cylinder is not attached.
Okay.
Once the cylinder is attached, it will start giving you the warm CO2.
Humidifier
No, it is no.
Not humidifier.
Yes. So this way,
it is 30 liters means maximum 30 liters.
yes, 30 liter means maximum flow rate is 30 liter.
My question is there. When we are using varies, we are putting it on 1 liter per minute.
Yes.
When we are using this cannula, we have to change it.
Yes, you have to change.
Do it automatically.
No, you have to change. Once you attach the cannula, you have to change it to the high flow. That your assistant will come and it will press it and increase it. High flow is 6, average.
Why would you have to use medium?
That is medium is 6. In some of the insufflator, according to the manufacturer, some of the insufflator, they don't give you the manually to set to the 6. They give 3 setting, 3 programming. One is low flow, medium flow and high flow. Low flow means residual, medium flow means 6, high flow means emergency.
So I will not change if it will go like 1
If you will
liter.
keep 1 liter per minute, you will not be able to continue your surgery. Because it doesn't matter how much careful you are, little gas leak is always there. And suppose you are changing the cannula or you are changing the reducer, some leak happens when that's how the interior milieu is maintained. Because as soon as some breach in the continuity, some CO2 leaks out, which doesn't allow the external environment bacteria to enter into the abdominal cavity. That is one of the advantage of laparoscope. So leak has to be there a little bit. Even it doesn't matter how much airtight your cannula is there, little leak, maybe 100 ml per minute also is there. Because it is not metal and it is not a rubber abdominal cavity. These are muscles, these are peritoneum, some leak will be there. But those leak, that much leak is accepted. That much leak is okay. Sometimes it is good because it will not allow the bacteria to enter.
That means 18 liter
Per hour. 18 liter, suppose at the end of 1 hour you have used 18 liter. That means you should be happy. But at the end of 1 hour, if you have used 60 liter, you should be sad.
So this 18 liters in addition to the initial
No, altogether 18 liter. Because it will all keep on calculating till you reset it. So generally in the middle of the surgery you are not resetting it. Reset is only in the beginning. Reset will be done again in the next case.
But this
So after-
insufflator will show only maximum up to 12.4.
No, that was one fault in this insufflator. That is it's actually is not going more than 12.4, but it can go up to 100 also.
So actually air was being delivered, but
It is not increasing.
the digital interface.
Yes.
So after virus needed, we will change before entering the first trochar, also change in trochar mode.
Pardon?
This virus needed mode or trochar mode, just trochar mode when we will actually say.
No. The total amount of gas used,
Total, not the flow rate.
flow rate will be only at a time of variation, it will be 1 liter per minute. And once you put the trochar, it should be medium flow, 6 liter per minute.
You understand, but trochar mode just immediately I will change
Yes. Immediately you will change after putting the trochar.
after putting first trochar.
First trochar. As soon as your first trochar is in, it is changed to trochar mode. If you have kept it for 1 liter per minute, there is no problem with the safety of the patient. But immediately you will recognize that your pressure is not building up and it will draw your attention and you will tend to increase the flow. Because at 1 liter per minute, I will just give you the practical. Like see, so setting into the 1 liter. First I am setting to the high flow and here this is distended. Isn't it? Now I am putting to the residual mode and see it is collapsed. Now how much time it is taking? You have to go and take a cup of coffee, then let it again to build up.
Because I used to see like this is happening.
If this is happening, that means setting is wrong.
Yeah.
And it is.
It's happening.
But if you will put to the cannula mode, now no problem. See, as soon as I am collapsing fully, but as soon as gas leakage stops, automatically it gets distended quickly. Isn't it? So you have to keep and cannula mode is not dangerous because it doesn't think that if I am putting high flow, it will flow high. It will be decided by according to pressure. Flow high, it doesn't. A car which is a sports car which can go up to 350 km per hour doesn't mean as soon as switch it on it go to the 350 km per hour. It depends upon what is the traffic. What is the traffic? If traffic is not there, it can run to the 10 km per hour also. But it is ready up to 350. That doesn't mean. It is very intelligent. Now, cylinder. Once you buy the cylinder, once you buy the insufflator, they give you one cylinder which is of 2 kg capacity. This. And 1 kg contains at 22 Pascal pressure, 1 kg contains 22 liter of the CO2. So in this 2 kg there is 44 liter insufflator. So if you are not leaking, if your cannulas are new, if your incision of the trochar side is small, very good, then you can perform 2 surgery with this. But if you are doing the big surgery itself has taken the 2 hour, 3 hour time, then maybe in the half of the surgery it will be finished. So generally this insufflator comes with the new, if you will buy the new machine, then it comes. And the cost of this insufflator, this cylinder is approximately 1000 rupees only. It is good for freelancers who do surgery from one hospital to another. They can have 3-4 cylinder and they can put in the car, in the back, in the dicky, and they can go from one hospital to another. You don't need to carry the bigger one. In the hospital generally it will be the central supply, or you can have the bigger cylinders. Cylinders are different sizes. And the CO2 is available in the market in kgs. So what you should do, in this a small cylinder, if they want, they can put 5 liter also. And you will never know.
Yeah, it's heavy.
Isn't it? It is heavy. How you will know that? So you have to weigh it. Because once CO2 is compressed, it turns into the liquid CO2. And sometimes if you will not weigh, they will do the cheating. So you should give the money by weight. All the nuts should be trained that before giving CO2, they should weigh the cylinder. And once they bring the CO2 filled it, they should weigh again. And give the money according to the amount of CO2 which they have filled in. Isn't it? Otherwise they will always feel the less pressure. And sometimes what they do, they put some water. Suppose there is a 10 kg cylinder, in that they put 5 kg water and 5 kg CO2 or nitrous or gas or LPG also they do. In the gas cylinder, in the LPG in the household.
So how you will know?
You will know only if you weigh. Like if they will put the water, this is the problem for them. Because once the cylinder is empty, water cannot come out. And if you weigh the cylinder, instead of, if suppose empty cylinder weight is 5 kg, then with the water it will be 6 kg. So next time also they have to, yes, then 6 and 8 you will give the money of only 2 kg. So one time, after cheating one time, they will take the water out and then they will put the CO2 only.
But you will take 6.
Pardon?
But you will take 6.
Yes. But one time, but from next time they will keep it only CO2 so that they can get the money for CO2.
What happens to patient safety?
Yes, not only patient safety, it is bad for the machine. Patient safety is not an issue. Do you know why? Once the CO2 becomes liquid, it is so high pressure that any bacteria cannot survive on liquid CO2. Isn't it? And together with the water, keeps the pressure of the water also high. So water doesn't also get petrified. CO2 is so rapidly absorbed gas that it gets diffused in this complete water. And then any aerobic bacteria at that high pressure in CO2 environment cannot survive. So it becomes completely sterilized at that pressure. So safety of the patient is not a problem. Problem is maybe if it is completely some anaerobic bacteria, then I don't know. Maybe some research has to be done that is there any possibility of any anaerobic bacteria in this water, and it may be not published anywhere, but it can be theoretically.
And with LPG?
And LPG is for the cooking in the kitchen. So LPG will not create problem. LPG means?
But it is liquid petroleum gas.
Yes,
but
but
it is,
why you are talking about LPG?
you said LPG also mix
No, sorry, I didn't tell you this. I tell you that even the LPG vendor, they put water in it.
Okay.
Don't put LPG. It will be a big problem, you know.
That's the impression I got.
Yes, no, sorry. So, I'm sorry if I could not explain. Actually, LPG, if you will put and you use the current, you know, it will die. The cell will die. So, it is same thing which they do with the LPG cylinder. So, this is very important that we should weigh the cylinder. Other problem is, any time don't put the cylinder lying down. It should be erect. Here also there is one connector. If you see, it is erect up. It is not lying down. Because if it is upside down or lying on the floor horizontally, then liquid CO2 enters. Because by default gas goes up. So once the liquid CO2 enters, it may spoil your sensors of the insufflator. And sometime, if the water is there mixed, and if you are putting lying down, water enters and it will get spoiled. Now once it gets spoiled, there is a big problem that we will not know. Insufflator is putting 25 liters per minute and it is showing 12. Just like here was this is a mistake here, that it is not going more than 12.4. Suppose exactly same way if it is set, that it is not showing more than 15 anyway. Now it is a big danger, isn't it? There is a pressure of 18 but it is showing 12 only. Now how do you know this? Time to time you have to calibrate it. And how to calibrate it is very easy. What you do, you take one clasp and turn your nuts like that and tie a knot. And after that, wrap the BP cuff here. And then this BP cuff will be wrapped completely around this. And then attach this end to the BP instrument. And then increase little bit pressure in the BP cuff to come to the 10. And here put little gas to come to the 10. And after that increase it to 30. Now this 10 level should go to the 40. You got it? Means in BP instrument also the mercury level is millimeter per minute. Here also of mercury. That is also millimeter of mercury. Just like when you are pressing your arterial pressure with the BP instrument, same way if you will wrap it around and attach with the BP instrument, you can check the pressure of this glove's pressure. And that way you can decide that pressure is accurate or not.
If not increasing, that is.
No, if it is showing 20 here, the mercury column also should go to the 20. I will show you. So practically, I will put it, they will show you after lunch. So this is how the millimeter of mercury is checked. Now, another problem is, sometimes CO2 cylinder is exhausted. And there is no CO2. In those situations, sometime rarely you can use air insufflator. Isko upar rakho air insufflator. But don't take it official. If patient has air embolism, don't tell that Dr. Mishra has told me to use air insufflator. It is unofficial and it is unethical. This air of insufflator. But in reality, with safety, without any compromise, it can be used. Suppose you are doing cholecystectomy or hysterectomy. You have already taken the uterine artery and all, just colpotomy was required, just 15 minutes surgery was left. Then no need to convert, air insufflator is okay. Do you know why? Because there is no danger that it will go to the vein. If you don't have CO2, don't start your surgery with air insufflator. But suppose just in the 2/3 of the surgery is done, and then anyway CO2 cylinder is exhausted, then air insufflator. Only thing, take care that here also adjusting of the pressure is there. And you can switch it on, and then isko lagao to, isme power to, and then you can adjust the pressure here. Although it is analog, it will not give you, but it can set the maximum flow rate and set the pressure. Pressure and flow rate you can set it here. Yeah, see it is 12. And you see that? It is 10 and it is 12. And here it is flowing. You see the air coming. If you are stuck, it will show you like that. And this meter will let you know how much is the intraabdominal pressure. And it is not expensive. It is only 20,000, 25,000 rupees. You can buy it. Suppose that is also not there, then you can take one cannula and you can ask your nurse to put the pump. Suppose this is cannula and I don't have air insufflator also. Then also it is not necessary to convert the surgery to open. It is not necessary. So what you do, this is cannula. Now remove this and attach the tubing of the BP cuff here. And tell your nurse to keep on pumping. And this is the room air which is pumped, isn't it?
Yeah.
And then you can continue your surgery.
This is nice.
And the other,
Yes.
how is the other one connected?
Pardon?
All right. So this is the patient.
Yes. This is the patient. Yes. And it is insufferable. And suppose,
How much?
pardon? No. Suppose you want to know how much pressure, then it is also easy. What you do, you attach this tubing of the insufflator to the other cannula. And then it will give you the actual pressure. Because only CO2 is exhausted, your insufflator is correct. So now what you do, you attach the other cannula here. Can you see that? I will show you. Yes, let me make it airtight. And this will give you the actual pressure. See here, once the pressure will increase, the insufflator pressure will increase. Can you see that? It is increasing. Although it is leaking actually, because I cannot maintain the two cannula in the same gloves. And see now, it is 4. Pump karte jao 5, 6, 7, 8, 9. Yes.
So in this level, you
Now,
stop.
if this is she has the problem or he has a problem, it is leaking in between these two. That's why.
But he'll continue
Otherwise,
the
you
pressure
can
or
use the
stop
nebulizer.
in some point
Yes,
or
nebulizer
continue?
laga do. Otherwise, you can use the nebulizer.
No, sir. I mean, he'll continue the giving pressure or
Yes.
at some point stop.
Yes. And if you don't want your, actually it was open. If you don't want your nurse to get tired, then you can use nebulizer here. And that nebulizer switch on and off will be done by your assistant. Here. And only rakho wahan par. This is the nebulizer. And the pressure will be adjusted according to the need. So it is leaking in between.
In increasing pressure.
Wait, no, it will not leak. Still it is leaking, but anyway, so this way you can control it. And if the pressure goes high, you will keep on switching off. Isn't it? So this is immobilium pressure is maintained. Let me remove this one. Only one I am using. Then it will be easy. See here. But only problem, and do you know, if you cut it, okay? Yes. You know, sometimes you can split the tubing of the nebulizer. They have already cut it. So what is the idea? That excess pressure will keep on coming out. Tubing of the insufflator in nebulizer you can split. And it acts as a valve. Now see the pressure will be more. So there is it is cut already, longitudinally. It is leaking from here. You put the finger, it is leaking from here.
Instead of switch on the
So it acts as a maintaining the pressure. It is cut there. And this way you can maintain the valve. So
Pressure is not going.
no, it will not go because it is cut here. Excess pressure will keep on coming out from this split. In tubing you have to give one cut. So the excess pressure will keep on coming out. Otherwise it will burst.
That means continue that pressure.
Yes, then you can keep on switching on continued. But if it is not cut, you have to keep on off and on.
So before starting the surgery, we can, is there any method by which we can know how much amount of gas is remaining in the cylinder?
Yes, it is there. On the cylinder there is one pressure measuring gauge. And another, once the, इसको off करो cylinder को.
Sometimes in the machine.
Yes, here the machine it is there. Once the cylinder is going to be completely exhausted, it gives you the alarm. Like suppose once the complete CO2 will go out, here he has already closed it. And then you will see, पूरा बंद करो कसके. There are some CO2 already in between the insufflator and the tubing. That is compressed CO2. That is, once it will exhaust, you will see it become red. And then it will start giving the alarm.
Some machine it shows like a tubes.
Yes,
Amount of gas.
just like a bottle.
Yeah.
And the amount of gas is there, it will keep on lighting up. Now this is the alarm started, that means gas is exhausted. And then you have to change the cylinder. But if you are using a pressure measuring gauge over the cylinder, that is good. There is one meter over the cylinder at the top. Pressure measuring gauge is good for your insufflator also, because it will give you the controlled pressure, so that this cutoff of the insufflator will last for a long time. Because here it is electronic, that is mechanical. Am I clear what I want to? But problem is that pressure measuring gauge will give you the exact amount of the CO2 left inside the cylinder. So that is more accurate than the insufflator. So this is, now I will ask you few, but please keep in mind that these, BP cuff or air insufflator is medical legal problem. If something goes wrong, and if someone will complain, that nurse will say that this patient, we have used the air, then it is a medical negligence, and there may be a medical legal issue. So you have to do at your own risk and extreme careful.
How long we can use this alternate?
Maybe 5 minutes.
Oh, 5 minutes.
5 to 10 minutes. Unfortunately in India, in most of the blocks, the laparoscopic tubal ligation is done with the air. They use ambu bag to push the air, direct trochar insertion, ambu bag, and they do it. But none of... No, surgery is so easy and so quick that by the time you think air embolism surgery finished. One surgery doesn't take more than 10 minutes time, isn't it? And just 2-3 times ambu bag, air they put, go, and one fell up, another fell up, out. So it is not, but always fear is there, because accidentally if trochar goes to any vein and then air enters, air embolism will occur. So it is not ethical. Now I will ask you a few questions and you have to answer those questions. Question number 1. Pressured pressure is 12. You can write down those questions also, because sometimes it may be asked in the exam. Preset pressure is 12. Actual pressure is 6. Flow rate is 1 liter per minute. And total amount of gas used is 10 liter. In a 20-year-old nulliparous woman during diagnostic laparoscopy. Then where the gas is going? Again I will repeat, preset pressure is 12. Actual pressure is 12. Sorry, 6. Flow rate is 1 liter per minute and total amount of gas used is 10 liters.
In the bowel.
It is escape.
Okay, one answer is bowel. Another answer is it is leaking. Okay, third answer?
The flow rate is too low.
No, then where the gas is going? This is the question. Flow rate is not low. You know, very little flow rate you have kept to the one only.
20 years.
Pardon?
20 years. Not bad.
Operation.
Pardon?
20 years.
Young.
Yes.
The tubing's not secure.
Machine may be not
Pardon?
working well.
It's leaking from the varus needle because the tubing's not connected well.
Okay, leaking from the breast needle and maybe the tube is not connected well. Okay? Another answer?
Reading may be not well.
Pardon?
Machine reading.
Tubal ostia, it is leaking to the tubal ostia. Another answer? Still I am waiting for correct answer.
Absorption, sir.
Absorb? No, that much quickly it cannot be absorbed.
Machine may be not working
It is
well.
going in vena cava.
Not bowel.
I will tell you, if it is leak, then it is leaking into the atmosphere. Isn't it?
Yes.
And with the varus needle, always the pressure is pulsatile. And it will come not to 6, it will come minimum of the 5 reading will come to 0. It is going into the vein because the pressure of the vena cava is 6 millimeter of mercury. Don't worry, all the new question will give you the more answer of the first question. Now I will tell you the second question. Preset pressure is 12. Actual pressure is 12. Flow rate is 0.5 liter per minute. 0.5 liter per minute means 500 ml per minute. And total amount of gas used is 500 ml. Yes. Yes. Then where the gas is going? One answer is pre-peritoneum. Another?
In the bowel.
In the bowel. Third?
In the bowel.
In the
No,
bowel.
sorry. No, it's not in the
Bladder.
There is some obstruction.
Okay.
Winter.
Okay, one answer is there is some obstruction. Any another?
In the stomach.
Pardon?
Stomach.
It is in the stomach. Okay. Another? Correct answer is pre-peritoneum.
Yeah. Because it's not expanding.
Do you know why? Just like these gloves, within 100 to 200 ml, peritoneal cavity distant, and immediately actual pressure reach to the preset pressure. But still some flow is there. Why? Still the fibrous trabecules of the peritoneal membrane is detaching. It is stretching. Do you know maximum capacity of the pre-peritoneal cavity at a pressure of 12 millimeter of mercury is 1 liter. But this 1 liter is not achieved yet. Only 500 ml is gone there, isn't it? So after 1 liter, flow will stop because further stretching of the peritoneum will not be possible, and peritoneum lacks, distended peritoneum will touch the bowel and it will say enough is enough, now I cannot take more gas. Just like abdominal cavity, after 1.5 to 6 liter, it is stopping. It is not taking more gas at 12. If you increase it to 18, it will take a little more. But at 12, maximum capacity of the peritoneal space is 1 liter.
If more gas is taken, then we should suspect it is going in the subcutaneous.
Pardon?
Suppose same pressure 12.
No, subcutaneous I am coming. Now next question. Preset pressure is 12. Flow rate is 0. Actual pressure is 12. And total amount of gas used is 200 ml. Then where the gas is going? Then it is going either subcutaneous or muscle. You know, at 12 millimeter mercury pressure, surgical emphysema never happens. Only it can happen if the patient age is more than 70 years. Because their subcutaneous plane is very soft. If patient is young, 20-year-old girl, at 12 millimeter of mercury, surgical emphysema will not happen. So it is above the rectus anywhere, either in the muscle or in the subcutaneous. Only 200 ml it will go to one septa, and that means further gas entry will stop. Now next question. Preset pressure is 12. Actual pressure is 30. 30. Flow rate is 0. And total amount of gas used is 200 ml. Then where the gas is going? Pardon? Flow rate is 0. Total amount of gas used is 200 ml. Actual pressure is 30. Preset pressure is 12.
Someone is blocking the tube.
Yes. That means it is a block. That's why your question was not block at that time.
Sometimes when wind go around when you are putting the sneezing.
Then also block.
Yeah, there is the pressure
Block.
go up.
Yes. Now I will show you.
When it go to bowel, inside
Yes.
the bowel, what will happen?
I will come to that answer also. See here. I am switching on the insufflator, letting the CO2 come out. Gas, it is saying the gas is closed. Open. Bottle, it is writing bottle. Bottle is closed. Now he is opening it. And now it is checking. And error will go, and now it will come to the preset. Already all the 800 ml is escaped. Now let us see. I am making a very small cavity and I start the flow. How much gas has gone?
200.
Only 200 ml of the gas is there.
Pressure is on.
Yes. And then it comes to 12. Actual pressure is equal to preset pressure. And flow rate is 1 or 0. Isn't it? But actual pressure is not going more than preset. But as soon as I will block it, actual pressure will become high. It is how much now? Yes, and it give alarm. But if I will leave it, again it returns to 12. And it is not giving the alarm. Now tell me why it happens. If it is not flowing, that is also a type of block. Then it is not going high. When I block it, then also it is not flowing. It was previously also not flowing. Then how come this insufflator knew that it is blocked, and why it becomes now high, 27 and 73, 51, and why it gives alarm?
Sensory intensity.
Yes, so how? What is the mechanism? That we have to understand.
Volume decrease.
No. See, it has sensed that there is a block. If I leave it, it will not.
7 seconds.
Pardon?
7 seconds. After 7 seconds.
Pardon?
After 7 seconds.
Yes, after a few seconds. Why?
Resistance. High resistance.
But here is also high resistance.
Elasticity.
Elastic means there is a wave actually. What insufflator? If you will hold it like that in your hand, you will see just like arterial pressure, it is pulsating. What happens? That insufflator keep on talking with the cavity. It gives the impulses. And if there is any cavity, that wave is absorbed. So it will know that it is in the chamber. But if I will obstruct it, this is reflected back. And then immediately insufflator senses that there is obstruction. You got it? So even if it is 200 ml of the cavity, like in pre-peritoneum or like subcutaneous or like in the muscle, but if the cavity is there, insufflator will not give you alarm. But if there is a block anywhere, insufflator gives you alarm. Now where the blocks are possible? One block is possible that accidentally your varus needle is blocked. Or the varus needle is itself dirty. It is alarm. If I will open it, no alarm. Or suppose accidentally the eye of the varus needle, as she was telling, that it is wrapped around one of the piece of momentum, like this. And then it will give you alarm. See, it becoming 30, 24 more. Yes. So in those situations, what to do? In those situations, just you rotate it. And as soon as you will rotate it, I am waiting for alarm to occur. As soon as you rotate it, direction of the eye will go to the other side and this alarm will stop. If it is down, it is obstructed. Isn't it? But if I move it up, it stops. Another possibility is that your nurse was resting over the tube and tube become kinked. So remember, whenever another possibility is, it is in aorta. Then there is a complete black backflow because it is 12 and aortic pressure is 120. Or someone is pressing the abdominal wall. Then also it gives you alarm. So whenever alarm is and the actual pressure goes beyond the preset pressure, that means there is a block. Block may be due to the starting from tube up to the tip of the varus needle up to the aorta.
Can I ask?
That varus needle now again also pressure.
Yes. If it is started like that, and if I will close it, pressure will go 58, 59. Remember, actual pressure more than preset pressure, and if I will open, it will not give. Actual pressure more than preset pressure means there is a block. Now where this block is there, it depends upon the situation. That you have to find it out.
You know, when it is in the aorta, there will be a flow rate.
No. That's why it gives you alarm. If it is in vena cava, there will be flow rate.
Aorta, no?
In the aorta, how? Aorta pressure is 120 and your pressure is 12.
So it's high.
Yes.
Also suction torque is slow.
Pardon?
Block. So it's blocked. It's blocked.
Yes. Now, another question. Preset pressure is 12. Actual pressure is 12. Flow rate is 1 liter per minute. Total amount of gas is 1 liter. And there is a unilateral distension. Preset pressure is 12. Actual pressure is 12. Flow rate is 1 liter per minute. And total amount of gas is 1 liter. And there is unilateral distension. Bowel.
And the other
Pardon?
What kind of distension?
Unilateral.
This is unilateral distension, one-sided. You know, just like a coil of intestine, one side will bulge out and other side will be deflated. That means it is going into the bowel.
and you will hear noise.
You can hear it if it is there.
I am sure.
Okay. So, you know what happens? Bowel doesn't go, the gas doesn't go the entire bowel. Just like a valvulus, one coil of intestine pop up. Isn't it?
But actual pressure may go up now if it is twisted.
No, it is twist. It will not twist because it is already not an obstruction. and still the flow is maintained because it is going into the distal and proximal loop, but that particular coil of intestine will balloon up and it will give you one-sided bulge, isn't it? So if it is the bulge is suprapubic, that means it is going into the bladder. Most of the time it is not necessary. If it is left iliac fossa, most of the time it could be in sigmoid colon. If it is right iliac fossa, cecum or small intestine. And if it is epigastric, it could be in the stomach or pneumo-omentum, means it is going into the omentum. That is omentum ballooned up. Sometimes our anesthetist has a bad habit that during the pre-anesthetic, aeration, you put embo bag and they push a lot of gas, oxygen into the stomach. The stomach becomes so much distended that with the varus needle, it can be punctured. So it is always better that, especially in the upper abdominal surgery and in those situations, if you can see that costal margin, that rib cage and abdominal wall is plain, it is not depressed. Or if you palpate and you can see the tympanic sound over the stomach, tell him means yes, to put a NG tube, nasogastric tube, and after that gas will come out. So going into the bowel is extremely pathetic situation, and those situations, according to book, keeping there in the position laparotomy is required. But fortunately, varus needle, most of those injuries are self-limiting because it is a needle. But the same injury, if it happens with a trochar, you have to do the laparotomy and repair it. So these are some of the variables which we have to keep in mind. Now question is, if these are variables, what is the normal? Normal is total amount of gas used and the actual pressure. This and this graph should go parallel. Always parallel. It should never converge, it should never diverge. This preset pressure, so actual pressure and total amount of gas used. Let us take one example of 18-year-old man who is muscular, going to gym every day, very fit. What you will get? Initially within 100 to 200 ml of gas, liver dullness will get obliterated. There will be sound like a ripe watermelon. After that, as soon as the pressure started increasing, then within 300 to 400 ml, pressure will become 3-4. Within 600 ml, pressure will become 6-7. Within 800 ml, 8-9. Within 1 liter, 10. And within 1.5 liter, it will reach to 12 or 15. But see, the graph is going parallel. Suppose within 100 ml it was 0 and after 200 ml it becomes 15. That means it is in preperitoneum. Or after 100 ml it started giving alarm. That means blocked. Or after 100 ml it is stopped. That means subcutaneous or in the rectus. Isn't it? Or it is going and minimum of the 5 reading is coming 0. That means leak. Or it is getting unilateral distension, that means bowel. Isn't it? So this way, immediately it will, with insufflator is such a beautiful machine that within 5 to 10 seconds it will let you know where the gas is going. And if immediately you have recognized, then take the varus needle again and put it again perpendicular. But suppose you will recognize late after 1 liter of the gas putting in the preperitoneum, then again going through around the umbilicus is not possible. You have to go to the Palmer's point. Because peritoneum is so much distended that even if you go perpendicular, you will go in the same place. Or even if you do open technique, Hassan technique, you will go in the same cavity. Because peritoneum is completely detached. And once you will go with the telescope, you will not see the bowel, you will see that all over a spider web-like fibrous trabecules are there. And then only thing left for you is to turn it to the up and perforate the peritoneum with the telescope. That may be very risky. isn't it? Another alternative, maybe go with the Palmer's point, evacuate the gas from here, and once you will enter to the, because it doesn't matter how much peritoneum you make, gas doesn't go to the upper abdomen. Gas always go to the lower abdomen. Why? Because gas will go where it is easy to go. And the peritoneum is very lax below the arcuate line. Because below the arcuate line, posterior rectus is not there. And it is a lax peritoneum. So Palmer's point will be still intact. So you put the varus needle here, and then you put the trochar. How to put in the Palmer's point, that I will discuss. I will demonstrate to you. So this is important, that this sitting should be seen. Now another example of a 70-year-old grand multi-para woman. Within 100 to 200 ml, in that female also liver dullness will get obliterated. But up to 6 to 700 ml, pressure will remain 1-2. After 1 liter it will come 3-4. After 2 liter it will come 5-6. After 3 liter it will come 8-9. After 4 liter it will come 10-11. After 5 liter it will come to 15. But from beginning, if you see, the graph was parallel. And as a surgeon, your job is, just by seeing the patient, palpating the abdomen, you should come to know which graph she will get. Isn't it? Which type of graph of the flow rate and the total amount of gas in this patient I should see. And the variables already you know. That depends upon the size of the patient, muscle relaxant, parity, this, that, all. And immediately it lets you know where your gas is going. Some people, they use insufflator as a meter to know that your varus needle has entered into the cavity or not.
Yeah.
They put the varus needle first inside, and then they attach the tubing of the insufflator. And if you will see, because of the negative pressure, when I will pull it, it will show the negative. It should show the negative. Sorry, it was punctured. So, yes.
If it is contained, then you are inside the peritoneum.
No, not less. That much it will not go. 2-3 millimeters of mercury, negative pressure, it will show. It is not giving, just like if I pull it, this is negative. Because there is always a negative pressure inside the peritoneal cavity.
We always check whether it is in the peritoneal cavity and then only put the insufflator.
Yes. How to do with the varus needle? After putting it, irrigation, suction, hanging drop test.
Yeah.
That will let you know. And the last is quadromanometric indicator. So attach it, and within 100 to 200 ml liver dullness is obliterated, and then slowly it will set. So this is a beautiful machine, very good. And if you know your insufflator, many of your complications can be stopped. And you can work with even an ordinary insufflator better. Suppose your insufflator is only 18 liter, and suppose bleeding is more, then take care that first you irrigate little bit and then suck. So irrigating, you are diluting the blood, and then if you put the varus needle inside the blood, it will not suck the air, isn't it? And then you can wash it out. So in cases of emergency, in cases of difficulty, it is not a very good practice to tell your assistant to increase the insufflator pressure. It is always better that our corrective measures should be in such a way that we should not leak the CO2 more. We should make a habit to work with the minimum pressure and minimum flow rate. That means you are a good surgeon. If you are making high pressure, high flow rate, and total amount of gas used by you also is very high, that means you are not a good surgeon. Isn't it? And this way insufflator can be used. All the insufflator of the world has this quadromanometric indicator. That is preset pressure, actual pressure, flow rate, and total amount of gas used. Only the buttons are a little different, and sequence is same. Preset pressure, actual pressure, flow rate, total amount. Sequence is same. Then only they get the FDA approval and CE mark. So all the good insufflator is working like that. So is there any question now?
So is there any analog machine that we can compare this digital?
Pardon?
Analog manual machine?
Manual machine, you know,